now.
Okay. Hi everyone, welcome back to another virtual study session with Pre-Dental Universe. We have an exciting presentation today with Dr. Lees. And on that note, feel free to take it whenever you're ready, Dr. Lees.
Awesome. Thank you so much. I'm really excited to be here. Hello, everyone out there in the pre-dental universe. My name is Marinee Lees, and I am a general dentist. And I thought this session would really just be about sharing about what my path was to dental school and after what I did post dental school and what I'm doing now. So let's jump right into it. I do hope that you feel free to ask lots of questions, and I'm excited to get started. So I'll talk a little bit about my path to becoming a general dentist. It's not traditional, and so it's not necessarily one I would recommend, but I'll tell you a little bit about it. So I went to Lehigh University. It's a small school in Bethlehem, Pennsylvania. And at the time, I was majoring in biomedical engineering. So my heart was set on taking problems and solving them. And I was really solutions oriented. So I felt like engineering was the career for me. After I graduated from Lehigh, I went back home. I'm from New York originally. So I went back home and went to grad school at New York University. And I got my master's in biomaterial science. So the way I explain biomaterial science is basically the study of anything that people would consider putting in their bodies. So that means titanium for prosthetics or like a hip replacement or a knee replacement, or titanium for a dental implant, wink, wink, um, porcelain for dental crowns, you name it. If it's going to go in the human body, biomaterials science is looking at it closely. So I thought it was a perfect marriage with my biomedical engineering background, and I worked while getting my master's at the same time. And I had a wonderful faculty in the program who had great connections in the dental implant world, and he connected me with a job at a dental implant company. That company was BioHorizons. They're actually located in Birmingham, Alabama. And I worked as a product development engineer. So I was in a cubicle all day, every day, and I was designing surgical kit parts for their implant kits. And a very small part of my job was me taking my prototypes and going out to dental offices and sharing with our key clinicians that we worked with what the instrument was. And I really loved that part of my job, and kind of had this quarter life crisis in my, early to mid 20s, thinking, I went to all this school, I'm working in this field, and I don't think I want to do engineering anymore. I think I want to be a dentist. And so I called family up, and they were super supportive. So I have to say, having a good support system and changing your career in your mid 20s, it was a little bit of a jump, but I applied to dental school, and I was fortunate enough to get into the University of Texas Health Science Center in San Antonio. So that's really where the journey begins. But like I said, it's non-traditional. And whenever I talk to pre-dental students, I think a lot of people, they want to know what my path was. And even though mine was so specific and weird, I tell everybody that everyone's path is different. And you've heard the pathway to success is not a straight line. And I completely believe in that. I just think that everyone's journey's a little bit different, and try not to focus so much on someone else's journey and where they're at, but just focus on how you can make your journey the best experience. There's going to be, as you can see, like your plan is, flag at the end of the road. I'm going to get to dental school. I'm going to be a dentist. Life is great. But in reality, when you look at the lower picture, like that's what life is. You come across these really deep valleys and steep mountains. And I would probably say dental school is like where I'm on a lifeboat in the middle of the ocean in that deep valley. It's tough, there were times where I loved it, and there were times where it was very challenging. But I would say don't be discouraged and just keep going, because there's another part of your journey that's coming up. And if your journey sounds nothing like mine, that's totally okay. And you can always switch gears. So I'm very passionate about that. I think everyone's journey makes them the exact person and dentist that they're supposed to be. So if you have any questions, I'd be happy to answer that. So after dental school, really, I remember getting into dental school and thinking, oh my gosh, I just want to graduate. I did 4 years and I was ready for the real world. And there are so many specialties, and I'm not going to list each one out, but they're all here for you to look at. And I remember having exposure to each of these when I was in dental school and just thinking, like, wow, radiology, that's so cool. You can look at a panoramic x-ray and find some really crazy diagnoses. And oh, oral surgery is so fun. Like, maybe I want to be an oral surgeon. And pediatric dentistry, I was like, wow, I love kids. And then I did my pediatric rotation and I had a screaming 3-year-old and I was like, I don't like kids that much. So it's kind of like, some people start dental school knowing exactly what they want to do. And some people come out with a completely different result. But what I love about dentistry is that there are so many different types and you can make it what you want it to be. And so from radiology to public health and everything in between, I just loved having exposure to everything. And one of the reasons why I ended up choosing general dentistry was because it allowed me to do all of these things on some level, and I get great joy out of that. So after dental school, even though I swore up and down I would stop school altogether and just work as a private practitioner, I remember I was a third-year dental student and being so scared. And then as a fourth-year dental student, when we were teaching the incoming third years, when we were paired up with them, like, oh, this is how you take an x-ray, or this is how you give a shot. It was wild to me how much I had grown in 1 year. And now I was a fourth year teaching these third-year students, and I couldn't believe how much I learned and how confident I felt. And so I thought, wow, if I learned all of that in 1 year, I can imagine how much I would learn if I did just 1 year of residency. So I ended up doing an advanced education in general dentistry residency. And it was a wonderful experience. I think it's just such a good way to expand your skill set. And I really wanted exposure to more things. I was just like, give me all the things. I want to grow and I want to be the best dentist ever. And not only do more things that I love, but also have exposure to do things that I can quickly figure out if I don't like doing them, because it's important to know what you like, but also what you don't like, so you can shape your career to be a really happy place for you to be in, because you're doing it all the time, every day, right? So you want your career to be something that you really love doing. And for me, AEGD was very helpful in figuring that out. So I did my AEGD in East Carolina University, which is a dental school, a newer dental school in North Carolina. And my husband and I, when we were in Texas, we thought about all the places that we wanted to potentially live. And we thought an AEGD would be a really good way to get to try out a new state or a new city. And we just wrote out a list of all the things that we were looking for in life. So, if we wanted to be closer to family, or my family's in New York, his family was in Pennsylvania and Florida. So it was kind of like a happy medium. So advanced education in general dentistry was a good way to explore a state without having to really commit. And we ended up loving North Carolina. So I'll get more into that. AGD was also the perfect place for me to take on challenging cases. So this was one of my complex cases that I presented on when I was in the program, and I just love this patient. She was the happiest, most cheerful woman, and she hated smiling, which was tough for her because she was such a happy person. And as you can see in the picture on the left, I kind of showed you all my marbles here at one time. It's just, this is the before, this is the after, but we'll go through step by step to see how we got from point A to B. Really, her goal was to have a natural smile and feel comfortable smiling again. So she didn't need celebrity, super white, B1 shade teeth, but she just wanted to look like her original self when she was younger, and she wanted to be comfortable. And so what we did was we started with just, okay, where do we begin? And this was our first intraoral photo. There's a lot going on here. And this is a case that if you were in dental school, your faculty would likely take and say, we're going to give this to our advanced department because there's just a lot happening here. And so again, this is my little plug for AGD because it was such a great experience. But here we have a complex case where we have multiple missing teeth, multiple carious teeth or grossly carious teeth, which is actually a phrase that I don't really like saying, especially around patients, because if you ever say the word grossly carious, it's a dental term, but it sounds so offensive to a patient. It hurts my heart. So I don't normally say grossly carious. I'll just say extensively decayed teeth in front of patients. But you can see in all quadrants of her mouth, she has broken down teeth, and she was the type of person that always put her family first. And so her kids were grown up. She had her life back again. She loved rescuing dogs. Like, everything was about everyone else, and this time it was about her. So I think even for her to see her teeth up on the screen, it was like, that, I can't believe that's my mouth. We looked at each tooth individually, and here I think I have another yeah. So these are intraoral photos where you can see the upper and lower arches, and we have multiple restorations that have failed over time. We have recurrent decay, we have primary decay. We have an infection on the upper right quadrant there that you can see right where tooth number 3 would be. It's just a situation that had been neglected for some time and now was ready for some attention. And so what we ended up deciding was really matching her goals with a healthy mouth and a natural smile. And in situations like this, here's Pano, where you can kind of see she has multiple missing teeth, and those posterior teeth are super important. And we really wanted to restore her smile to a functional smile. Looks like I have 2 pictures there. Okay. So what we ended up doing here, I hope no one's eating dinner right now, but I should have given a little warning. This is a little gory. I left a lot more of the other gory photos out, so I think this is the only one that I have in there, where this was the surgery that we ended up doing for her. So you can see there's a black line, right? We reflected the tissue, which means we took the gums, made an incision, and did a full thickness flap where we lifted the gum tissue up. And then we did some measurements. And she had a lot of bone, and the teeth that were there were deemed pretty much non-restorable. So we do have a tooth with a crown on in front. The patient really wanted to start fresh, and she was very open to the idea of doing implant supported denture for the upper arch. So in order to do implant supported dentures, you really need to think about the space between your upper and lower arches, because you need to fit not only the implants in the bone, but the space for the denture to coincide with the lower teeth. And so that spacing, we needed to get some space, and bone is super important for implant placement, but we actually had too much bone here. So that black line is demarcating really how much we needed to remove from the patient's mouth in order to place the implants and fit a denture in there. So what we did was basically shaved off the bone from all of the facial aspects of these teeth, and very gently just took the teeth out facially. We just kind of pulled them out. It wasn't like a very extreme extraction, because all of that bone that was holding it in from the front side was removed. And we ended up suturing everything up. So we took an upper arch, full mouth extractions, sutured everything up, placed some implants, and here we go. So here's the pano of the post-implant procedure, where we have 5 implants on the top that will be supporting her maxillary denture. So she just snaps it in and it feels good to go. And this is her with her maxillary denture in place. I wasn't able to finish the lower case for her. I think she ended up getting maybe bridges on the bottom, but it was passed on to another resident. But just to go from a really broken down, unhealthy smile, to be able to take out all of those teeth in the upper arch and just restore her so that she has something that's very comfortable, that she's not worried about popping out when she's talking or laughing with friends. It was critical, and just seeing how happy she was the day that we delivered the implants and the denture for her just made me super happy. And this was actually immediately after we did the surgery, so she was like still sort of numb, still super happy. She loved the way the denture looked, and that's kind of just such an indicative case of what you can come across in your advanced education residency, where you take on these bigger cases. So I know that your mindset right now is like, I just want to get into dental school, and I totally agree with that. But just kind of planting the seed that maybe if you're interested in general dentistry, that another year, some programs are 2 years as well, you can add that to your education and grow tremendously. So immediately after my residency program, I went straight into private practice. So this is the first practice that I worked with. It was just such a happy family of people. You could see me in the center. I have my mouth open, and I'm sitting next to the owner, who is to the left in this photo, and her husband was right behind her. So it was really like a husband-wife team that ran the dental practice. She was the dentist, and he was more the business side of things. And it was a massive practice. This is the entire team. I think it was 21 people total. These are our hygienists, front desk, our assistants. I mean, it was just such a good place to start out. And I'll talk a little bit more at the end of the presentation about different types of private practices that you can get into. But this one was a good one because it had very much a family feel. I was there for about 2 years, and sadly they ended up having to close, and due to COVID, things really got tricky for a minute there. But the moral of the story is, like, your first job isn't necessarily the one you're going to have forever and ever. Amen. And I think that's important to keep in mind, because you can figure out, again, what you like and don't like. And I learned things that I liked the way that this practice did. And then there were some things that I didn't like the way this practice did. And I think that makes me a better clinician now. So now my schedule is so different. I used to work Monday through Friday, 7 to 5. And after COVID came and just rocked everyone's world, and that practice ended up closing, I took a really hard look at what I wanted my life to look like. And it was a little bit of like a soul searching moment, and a little bit scary and a little bit exciting. And when I was in dental school, there's a part of the dental school environment where you just feel like there's so much potential to learn and grow. And I didn't want to give that up. I think I've always been drawn to dental education. And so my schedule now is Mondays and Fridays. So today's a Friday. I was at the clinic today. I'm an adjunct faculty in the UNC's dental school. So what that means is I basically coach the third and fourth year students through their clinic sessions, and through the morning and afternoon sessions on 2 days a week. And it's just been such a great experience. And again, makes me feel super connected to pre-dental and dental students, because I know what it's like. I graduated from dental school in 2017, and then my AGD was complete in 2018. And it wasn't that long ago, but when I look back, I just see the tremendous amount of growth, and I just love it. So being back in the dental education world has been amazing. And I love being on the clinic floor because I just see such a wide variety of procedures and different personalities. And it's always crazy. There's always something cool going on. And it's been fantastic. So this is a picture of UNC's dental school. It's located in Chapel Hill, North Carolina. This is a shot of the inside. It looks a little bit different now with COVID. They kind of spaced out the couches and everything, the student lounge. But overall, I mean, the school and the students there are incredible. And if you are considering applying to UNC, then please reach out to me and feel free to ask me any questions. I'd be happy to answer any. And I hope some people are asking questions in the live chat. This is a private practice that I'm at now. So I'm an associate. I work for Dr. Amy C. She's the owner of the practice. She built this practice 16 years ago. And I think I have, a picture of the group. So I went from a very large practice to a much smaller practice. And I'm at this practice 2 to 3 days a week, kind of depending on the schedule and the need. And what's amazing is, so Dr. C is in the red with the glasses on the bottom left. She's so, so sweet and an amazing mentor. The women that are in this picture have pretty much been with her for the past 16 years. So when she opened the practice, these women were on her team and they've stayed, which was incredible to me. You just don't hear that anymore. They're all still there, with the exception of Corey, who's on the bottom row. She's in the middle. Her husband took a job 2 hours away a couple of months after I started working there. So we have another hygienist there now who I love and adore because I had worked with her in a previous office. And what's wonderful is that I have really good perspective on two totally different types of offices. So I'll kind of dive into that a little bit later. But really, I think so much of your dental career will be based off of the type of practice that you're in. My experience in the first practice that I was in right out of AAGD versus now, my days are totally different. I come home, I feel different, and we'll dive into that a little bit later. Okay, so I thought I'd just show you cases, just random things that I've done that I happen to have pictures of on my camera. Some of them are exciting, some of them are kind of basic, and this is one of those more basic cases, but it was interesting to me. So we had this beautiful patient come in. She's in her early 20s, and she's pointing to the upper left quadrant of her mouth, and we're looking at teeth 12 and 13 here. And she's an orthodontic assistant, so she knows dentistry. And she says, I have this black stain on my teeth. I've had these fillings done before. No one can figure out why my teeth are, when the fillings are done, they're normal looking, and then a couple of days later they turn the shade of black or gray, and I've had them redone before. Is there anything you can do? And I remember just thinking, like, wow, I don't know what could cause this, but I'm always willing to try. And so I explained to her, I think communication is really important. You know, we set the expectation where this is new, this isn't common. I've never heard of a resin composite just randomly turning gray a couple of days after placement. We talked about her diet, her medical history, any habits that she may have, and they all led us to absolutely nothing. So I said, okay, I'm going to open it up. I'm going to take pictures throughout the procedure. So again, a day in the life of a general dentist. You have a patient who comes in with fillings and doesn't know why they're discoloring and wants you to replace them. So what we did was I opened it up. I just went ahead. We got her numb. And I started cleaning out the existing restoration. Now, this filling had been done 2 times previously. She went to fantastic dental offices, not a bad word to say about them, but even the previous dentist was just like, I don't want to touch that tooth or those teeth anymore. They're just going to stay gray. And so that's when she decided to seek out a new dentist. So I went ahead, I cleaned both teeth. Unfortunately, I don't have a picture of both. I think I was so excited when I was working on this to just see it unfold. I'm happy I even stopped to take this picture. But as you can see, once the resin was removed, it was very dark and very black. And it wasn't soft, it wasn't decay. But what we're thinking is that perhaps the previous dentist in his bonding procedure had done maybe some sort of like silver diamine fluoride, which happens to turn teeth black. We don't know, but what ended up happening was a beautiful result. So 12 and 13, I said a little prayer, kept my fingers crossed, and got a text from her a couple of days later saying that her teeth are still white and beautiful, and she was thrilled with the results. So that was one of those moments where And I feel like this happens more than I'd like it to in dentistry, where you're given a situation and you're not exactly sure how it's going to turn out, but you just kind of roll the dice and rely on all of the knowledge that you've gained over time. And thankfully, we were able to solve the problem for her. So, very straightforward case, but with the proper bonding and proper resin protocol, we were fine just redoing the fillings. And thankfully, that was done over a year and a half ago, and we're still in a safe zone. So, no discoloration there. The next is pretty straightforward, but a fun case. I think one of the most exciting things as a general dentist is to be able to restore someone's smile when there's an emergency, a missing tooth situation, a fractured tooth, and that's exactly what this was. So, patient came in. I think I have another photo here. Yep. So he came in kind of in a little bit of a panic where his front tooth had broken off and it was non-restorable. Actually, we took some x-rays, we took a look at it. It had an infection at the root tip, and we were not going to be able to restore it with a root canal. There's just not a lot of structure there to really put anything on. And so we had to come up with a plan. So in this case, we talked about our options. Really, when you have a tooth in the front that's non-restorable, or a tooth anywhere that's non-restorable, that's bound by two other sound, safe teeth, you talk about really the first option is always one, you could do nothing. That's a terrible option, but we always present it just so patients know that they're never forced into one particular option or another. The second option is to take this tooth out and put an implant there. Let the bone heal up, put an implant in, or possibly do an immediate implant depending on how much bone we're starting with, and put an implant crown on that tooth and restore the space. You don't touch the adjacent teeth. It's a really nice solution and probably the gold standard nowadays. And that's a permanent solution. Another permanent solution is to take this fractured tooth out, the remnants of it, and do a bridge. And a bridge is where you prepare the adjacent teeth to that edentulous site, and you do a bridge that connects the two teeth that you've just prepared and this missing tooth in the middle. They're kind of all bound together. Bridges were the gold standard at some point many decades ago, and their success rates are pretty strong, but there's a lot of things that can affect that. The patient's bite, if they have any parafunctional habits, are they clenching, are they grinding? What do those teeth's roots look like? There's so many things that you need to consider, but a bridge is a potential option, and it's also permanent. You cement it and then that's it. And then there's also a removable option where you have a retainer. Most patients call that a flipper. And the retainer, you pop it in, but you have to take it out at night. You can't sleep with it. And it's really not the best long-term solution, but it is a replacement option that is removable. And so whenever I have a patient present with a situation like this, I really go through those options. You can also do, depending on the replacement situation, you could do a Maryland bridge, where if the two teeth next to that space are sound, you can have this floating tooth where it kind of has wings and attaches to the sound teeth. And a Maryland bridge is a great option as well. You also want to look at how the patient bites together. It's permanent, it's a good solution, and it's pretty conservative as well. For this patient, we talked about all of the options, and he wanted a bridge. He didn't want to go through the process of an implant. He didn't want anything removable. He had I think it was his daughter's wedding that was coming up, and we were kind of on a little bit of a time crunch. So what ended up happening was I ended up preparing the adjacent teeth, and we did a bridge. So in one appointment when he came in, I prepared the teeth next to it, and then I took the tooth out. And the reason why I did it in that sequence was because I didn't want to take the tooth out and then have just all of this blood everywhere and have it be very difficult to manage. So the sequence of how you do things really does matter. We ended up preparing the adjacent teeth and then taking the tooth out. You can see that little cystic infection on the side of the tooth. It was infected, and we were just glad to get it out. The next step was to let it heal. So we really have to let it heal. And this was our final prosthesis. So this is the bridge. It was an all ceramic bridge. It blended in pretty nicely with his aesthetics and the existing shade of his teeth, and the patient was thrilled. And it was in a timely enough manner to where he can get to that big event that he had coming up, where he was seeing a ton of family. This is another situation that I wanted to show you where the patient had an almost identical situation, just one tooth over, but his option choice was different. So instead of doing a bridge here, the patient opted for the gold standard, which is to do an implant. So an implant was placed, and it was actually already placed at this point in time. So let me see, I have a close up here. So if you can imagine, I don't have a good picture of the like occlusal view of it, but the implant's placed there, and you can see that the tissue has kind of been molded and is healing around a healing abutment that helps that tissue emergence profile just really fill out and become beautiful. This was such a fun case because he had a lot of characterization on his existing teeth. He wanted his implant crown to blend in. Of course, we can't do a super white single tooth there. That would look insane. So this was a challenge for the ceramics of this implant crown. It has to blend, it has to look natural, and you can see all of these vertical craze lines on tooth number 9, and then 10 is the one that's missing, but 11 also has that vertical craze line. As far as shade goes, there are so many different shades in this one single quadrant or anterior area that we're looking at. We see yellows, we see a little bit of chromatic browns, we see some whites, some hyper white areas, that gingival area on number 11. There's a lot going on. And I think that one of the most exciting things about restoring teeth is having it blend in to where you cannot tell which tooth is the prosthetic tooth. And so this is how the case ended up. We worked with a local lab. I sent pictures, I sent shade tabs, I sent the patient to the lab, and we had the ceramist look at him in living color, in person, so that we can get the shade right. This was the first time that we had tried the crown in. Thankfully, we didn't have to send it back to the lab to do any further characterization, and it's seamless. It actually makes you look at tooth number 7 and think, oh my gosh, that's the tooth we got to work on next, because the incisal area is chipped. But what's beautiful about this is that the adjacent teeth were not touched. We didn't have to do anything to them. And the crown just blends in beautifully. And I have this case posted on Instagram. What I should have done was ask people, which tooth do you think is the fake tooth here? I'm sure we would have gotten all sorts of different answers, but it is tooth number 10, and this is a perfect example of an anterior implant crown with great results. Okay, so this is another situation. Oh my gosh, I love this patient. So she came to us. She was unhappy with her smile. She had somewhat of limited funding and just didn't know what her options were. She also ended up having some pain on tooth number 7. You can see there's a large cavity underneath that enamel there. She has an existing filling. Obviously, that filling has failed, and that's why she has an infection there. And this is a good example of aesthetics where you can really elevate the smile. So this is what we ended up doing. This is also a good example of, yes, would I have loved to include the canines in this? Absolutely. Absolutely. But could the patient afford it at that time? No. So it's one of those things where as a dentist, I notice all the different things, little colors here and there, little shades, different teeth that I would love to have included in this. But this absolutely elevated this patient's smile and her attitude about her smile. So to go from carious, multiple restorative on all the front 4 anterior teeth. On the lingual side, she had just like a hodgepodge of resin composite fillings. We ended up doing, so it was a root canal on number 7, that was the lateral, and then all porcelain crowns. And again, her thing was, it's got to look natural. I don't want to have super white teeth. I want to get the rest of my teeth done at some point, but I could only afford the front 4 right now. And we really just worked to create, you can see that incisal natural translucency, and she was thrilled. So this was another really fun case. Okay, this was a case where it was just like I saw this picture and I thought, oh my gosh, I remember this appointment, and it kind of goes to show that as a general dentist, really anything can walk in your office and you just have to be prepared to deal with it. So here we have such a sweet patient. She came in, she was in a little bit of pain, really not overly anxious or upset about it, but said, hey, I have a little bump. I'm feeling a little bit of discomfort. Can you take a look? When I lifted up her lip, I had no idea that the abscess would be as significant as it was. And this is an example. You can see tooth number 6, that canine was just so badly infected. We ended up having to do an incision and drain, which I don't have photos of, but this is a challenging case because you really have to make sure that the patient's medical history is okay and understand what the issue was. In her case, she had no cavity on the tooth, but there was a periodontal issue where there was a lot of bone loss due to this abscess. So we ended up draining it and giving her antibiotics. The sad part about this is I don't know where this case ended up. The office closed. I haven't seen her since. I have no way of getting in touch with her, but this is a great example of what can present in your office. And what's funny is today at the dental school, we also had a case for a student where he was planning on doing a filling on the lower left quadrant, but the patient came in with an abscess on another tooth. And there goes his afternoon plan. We have to kind of think on our feet. So we ended up doing an incision and drain with him as well. But just goes to show anything can go in and out of your office. And this is one of those cases where I just thought, wow, this is one of the biggest abscesses that I've seen in a long, long time. Okay, so I included this case because I also didn't want to show just the wins, but I did want to show, we'll call it not a loss, but a challenging case. We'll call it a challenging case. So patient presented to the office with an implant and a space. And he initially on the lower anterior teeth had a bridge. And that bridge ended up breaking, and he went to an oral surgeon's office. We didn't see him until he came into our office with this implant. So it was unfortunate that as a restorative dentist, I wasn't involved in that part of the treatment plan, but I definitely understand why they did one implant and not two. In this case, you can see there's really a thin ridge, and there likely wasn't enough bone to anchor an implant into. So the challenge here is to do an implant crown that we're going to screw into this particular implant, but it also is going to cantilever and have another crown attached to it so that we can fill that space. Well, I sent the case, we took impressions, I took pictures, I took shade tabs, everything, and I sent it to a lab. And this is what we got back. Yikes. So you can see it looks like 2 marshmallows. The patient was so excited when he came in for this appointment. He was ready to go. Yes, I'm going to get my teeth today. And I put these in and I said, there's no way I can let this man walk out of this office like this. Like it just, whoever had designed the implant crowns, and to no fault of their own, I really learned from this case to be incredibly specific in my communication and what I'm looking for. These crowns were very bulbous. They were very bulky. The shade didn't match. It is a challenging situation with the cantilever because you really want it to look natural. The patient didn't mind the shape of it, actually. The patient didn't like the shade. That was the only complaint that he had. But it was one of those cases where I thought, oh my goodness, like this is a total mess. And so that happens in dentistry too, where you're scheduled to have the patient come in and deliver these crowns and it just doesn't look right. And so I wanted to show this miss because we were all devastated. But anyway, and by devastated, I mean me and my assistant. And I think the patient was just like, I don't like the shape. Can we get this redone? So what I ended up having to do was I took lots of photos, side photos, profile photos, like every occlusal shots, everything to show the lab technician why this implant crown cantilever situation was so bad, and really was very specific in we need a different shade, we need a different contour, we need to make these blend in as much as possible. Because when you have that over contoured, bulky situation, you also can induce problems for the patient down the road. Very difficult to clean. The gingiva just doesn't respond well because it has this giant marshmallow cantilever thing sitting on it. So we ended up sending it back to the lab. This is what we got back. It's better. Now, it's better because it's the lower teeth, the mandibular teeth. So his lip is never this far down. So we'll say that. And then also the shade is better, the contour is better. Eventually, the goal is to have those two central lower mandibular teeth there recrowned because they were part of a bridge that clearly was sectioned. And so you can see that little gap there. But the cantilever crown off that implant is perfectly contoured. It blends in with a smile. It's not as shocking as this is. And so really, I think so much of dentistry is about communication, not just with your team, not just with your patients, but with the lab technicians. Because if we're not giving them direction, they really can only pull from thin air what to do, you know? And so this was really a situation where you can't just say, I need an implant crown on tooth number 26 cantilevered with 25 in shade A2. It isn't going to work. And so I think that it's really important to hone those communication skills and get comfortable with being very explicit about what you want. This was just a great teaching situation. The patient was thrilled. We ended up with a much better result, and all around we were happy. Again, this is just to show that stark contrast of like marshmallow to natural teeth. This was another case that was fun. It really, the pictures I wish were more like dimensionally the same, and I could have done a better job cropping it. But we had a tooth that was broken, had a huge amalgam filling that made it gray and black. We ended up doing a crown on that. This was the day that I cemented it. I have another picture somewhere that I have to find where after cementation and the gums weren't pushed out of the way, you can see it's just super natural. And that's what a zirconia crown can do. That crown was all ceramic, and just this is where the lab gets it right? We get that shade match perfectly. You really kind of glaze over that tooth. You think it's natural compared to the left picture where it really wasn't super natural. Okay, so this slide just talks about general dentistry and the things that I do in practice. So restorative, you guys have seen a lot of restorative things. That means fillings mostly, and we do a lot of fillings. Prosthodontics, so crowns, implant crowns, onlays, veneers, things like that. It's very much a part of everyday life. And then you also have pediatrics. So move this out of the way. So for pediatric, like I said earlier, I love kids, but I definitely think that there's certain situations where kids who are very anxious, very afraid, or just not really agreeable with direction in the chair, that they belong with someone who is a pediatric dentist. And I love making referrals out to our local pediatric dentist. But for the patients that I've developed really great relationships with and whose families I've treated for a couple of years now, I'm so happy to see their kiddos in the office. And I just want it to be a great experience for everybody, but that's all I care about. So if it means a better experience at the pediatric dentist, then I'm so happy to write a referral. But if they're comfortable with me, I'm so happy to treat them as well. So we do a lot of pediatric dental work. Cosmetic, you've seen a couple of cases of that today. We definitely do cosmetic work, and that's so rewarding. Oral surgery, I love oral surgery. I'm doing a lot more of it in the office that I'm in now because my owner, Doc, she also does a lot of extractions and site preservation and things like that. So oral surgery is very much a part of everyday dentistry for us. Endodontics, I don't do as much of it now, mostly because I have such great offices here to refer to. And my criteria for referring out is there someone who could do this faster slash better than I can? And if there are people in the area that have microscopes and are doing root canals all day, every day, I'm so happy to refer them out. Every once in a while, you'll get a patient who is just like, please don't send me anywhere else. And I'm happy to do the endodontics for them. But I've done less of endo since I've been in private practice. In my residency, I did so many cases I lost count, and I loved it. And Invisalign. Invisalign is very much an important part of just kind of your toolkit, especially if you're doing cosmetic dentistry. You really do want Invisalign to be a valid treatment option because you don't want to have to cut on teeth if they don't need to be cut on. If it's just mild rotations and little corrections that you can make here and there, clear aligner treatment is a really great way to go. And so when I was in dental school, we had the option of being Invisalign certified, and I took it and I loved it. And I am so excited to be able to provide that as an option for patients. And I think it's a really great conservative way to treat people. Oh, and then here we go. So private practice, I kind of hinted at this earlier, and the differences between the practices that I've been in. The large practice that I was a part of, we had 2 docs, we had 4 operatories for us, and then we had an additional 4 operatories for hygiene. And it was just a massive and beautiful practice. And it was a PPO, primarily PPO practice, which means basically, I think it was something like 80 or 85% of our patients had dental insurance, and we were in network with the insurance company. So we said, yes, we're going to sign a contract. We're in network with Delta Dental or Guardian or whatever the dental insurance company was. When you're a PPO and you sign this contract saying, yes, we accept your insurance, what you're accepting essentially is the fees that that insurance company then says your work is worth. So a good example of this is if we're to talk about a crown, and I'm going to use very basic numbers just to make it straightforward. If, let's say, I charged $1,000, I felt like the work that goes into a crown after I spend time working on the patient, after all the materials that I use to get impressions and make them a temporary or send it to the lab bill, the people, the personnel that I have to pay to be in the office at that time, the electricity and all of these things, it makes sense to, let's say, okay, $1,000. That's how much my crown is. When you sign up with an insurance company, you can say, hey, Delta Dental, my crown is $1,000, which is actually very inexpensive for a crown. But hey, Delta, my crown is $1,000. And Delta says, well, that's great. We have a contract with you that, and we have 800,000 people in our network. We are going to tell you what your crown, what you're going to get for your crown. So that means, instead of $1,000, Delta is going to say your crowns are $700. And so you think, okay, that's $300 less than what I would charge, but I'm going to be exposed to all of these 800,000 insured possible patients. So, okay, I'll bite. And you end up getting in these contracts where you have these insurance companies that are essentially devaluing your work. When that happens, the pressure is then on for you to see more patients, because in a certain amount of hours in a day, what you used to make, let's say you made, again, simple math, we'll just go $10 an hour. You work 8 hours a day, $10 an hour, that's $80. If you sign with an insurance company that said, no, you're not going to charge that much, we're going to charge you $5, then that cuts your daily production in half. What you used to make is now half. So what does that mean? That means you really should be seeing more patients per day so that you can maintain that amount that you had before. That's where things get really dicey because a lot of dentists feel pressure to be part of these PPO networks, and they end up feeling the need to squeeze more patients into their day to really stay productive and keep the office going. When you're in a fee-for-service office, which is the office that I'm in now, if we say a crown is $1,000, that's because we've figured out that that's what the cost of the crown is worth. That's how much, after taking out all of the expenses that we put into it, lab fees, personnel fees, rent, all this stuff, that's what makes it worth it. If the patient in your practice values you and values your work, then they'll continue to see you. And you don't have to sell yourself short with an insurance company. You just know at the end of the day what your stuff is worth. And that's really what fee for service is for me. Initially, when I had worked in the PPO office, we were seeing somewhere between 9 and 10 patients a day in our own columns, like that I would do treatment for. And then with hygiene, they had, let's say it was 8-hour days, we had 2 hygiene, that's 16 patients that you have to go in and check on. So between my, let's round it out, 10 patients that I see that day, I have 16 others that I want to spend time with and talk to and chat with, and how's your grandma? You do that in between you're working with these 10 patients. In the fee-for-service office that I'm in now, I see 6 or 7 patients a day. And our situation is a little bit unique because we just have one hygienist, but she has 6 or 7 patients a day, maybe 8 max if she's seeing them on the hour. And the feeling is so different. I'm not getting up and rushing in between my fewer amount of patients. I get to spend more time with people. Our new patient exams, both Dr. C and I, we do them ourselves. So that means the new patient comes in, I introduce myself. Hi, I'm Dr. Lees. We're going to work you up today. We're going to get pictures. We're going to get x-rays. We're going to talk about each tooth individually. We're going to go on a tooth tour. We're going to take a look at everything and come up with a game plan for you. I spend 2 full hours with every new patient in this fee-for-service practice. I get to know them. I get to know their families. I get to know their dogs' names. I get everything that gives me joy I get out of being in a fee-for-service practice, because I get to dive deep, not into only the medical history and the dental history and the patient's goals, which is really important, but also the person themselves. And the office is small. All of our assistants know all our patients. I mean, it's just such a family feel that it gives me such joy to be able to wake up and go to a practice where you just don't feel that pressure to see patients because an insurance company dictated how much your work was worth. And that's really, I didn't understand that when I was in dental school and even when I was getting out. I mean, that wasn't even a thought in my mind. I just cared about, was this practice an ethical, happy place that I can be? And the first office that I was in was very ethical. And they ran things with that family feel as best as you could, with heavy insurance breathing down your back saying, you're only getting half of what, you really should be getting. And so I will say, as you go into your journey through dental school and thereafter, fee for service, it's some people, there's this rumor out there that like, oh, fee for service is dying. And I really don't believe that. I think that as a dentist, if you value your work, and I pour my heart and soul into every single patient. There are times I come home and I'm like, oh, wow, I'm over analyzing the exit angle of a restoration, or could I have added more characterization on that crown, or how could I have, I live and breathe this stuff, and being in a fee-for-service office allows me to live and breathe it without the stress. And really, I just get to know my patients so much better, and the pace is slower. And if you think about it, let's say you were to have like a medical procedure. you don't want to go to the surgeon that's like, got to make this quick, let's go. You really want to go to someone who's like, I know this person, I want to take good care of them, I want to have my time to do it without rushing. And so everybody's different. Some of my closest friends are in heavy PPO practices and they love it. They love the hustle and bustle and like, going back and forth between hygiene and their procedures, and it works for some people. But I really want people to understand that fee for service, it's not dying off. I do think that it's a little bit harder now than it was 30 years ago, 20 years ago, to find a fee for service office, because these insurance companies are just so prevalent and everywhere. But once you educate your patients on what dental insurance is doing for them, dental insurance is not like medical insurance. Dental insurance is dental benefits. You paid for a dental benefits package. Your benefit is 2 cleanings a year, a set of x-rays, an exam, maybe an emergency exam. That's your benefit. Aside from that, insurance really, they'll find every reason to really deny treatment. But with that said, even in a fee-for-service office, our front desk ladies, they'll process insurance paperwork for patients. I write letters to insurance companies all the time explaining why patients need treatment. I'll rewrite letters and argue with them again after they've been denied to get my patients the maximum amount that they can have of their benefits. I will always, we have patients in our office, we're 100% fee for service. We have patients in our office that have insurance. They will process the paperwork for them and the insurance company will reimburse them directly. And we're taking ourselves out of the picture. And I think that that's just really such a blessing. And I just want to plant that seed for you guys, especially if you're considering general dentistry, to not give up hope and just think, oh, you have to go into a corporate dental situation to pay off your student loans or, just do PPO because it's the only thing out there. There are other options. And as a patient, now that I know the difference between the two, I can't imagine ever going to a PPO office for dentistry because I just know the economics behind it, and it's not really beneficial for anybody. And that's pretty much it. So here's a couple of ways to contact me. You can always reach out to me on Instagram. My handle is Dr. Smylees. And my Gmail is marineelees@gmail.com. I love hearing from people, pre-dents, especially because you're just starting such an exciting journey, and I want you to feel empowered. I want you to feel educated. I didn't know who to ask. I was in the engineering world. I didn't have any dental friends. I didn't know who to ask about specific things. But if we ever want to have further conversations about loans, finances, how you're getting paid as an associate down the road, these are all very important things that will affect you when you graduate dental school. So the more educated you are on it now, the better prepared you'll be. So please reach out to me. I would love to hear from you. And I hope we have some questions. How are we doing, ladies?
Yeah, we're doing great. Thank you, Dr. Lees, for sharing your unique experience with us and for preparing this presentation. With that said, we have a few questions in the chat, if that's all right.
Absolutely. Let's go.
Okay, so the first question is, so someone heard that UNC hardly accepts any out-of-staters. Would you recommend pre-dental students to still apply? And if so, what do you recommend to stand out and strengthen their application?
Okay, so this is a great question. As a little background, I went to San Antonio in Texas, and they are also notorious because it's a publicly funded school. There are actually rules that say that you have to accept a certain percentage of your student population to be in state. So that's not necessarily like a snotty or, like North Carolina club thing. It's just kind of the way the school's funded and the procedures that go along with that. As an out-of-stater, I did apply as an out-of-stater for Texas. What I ended up doing was making myself and my name familiar. I can't tell you how critical it is to hone in on a school that is your ideal and to not be afraid to reach out to people that are there. So use me as a lifeline, use me as an example. if you're interested in applying to a school, you have to go to people who are connected to it. That could be through alumni, which may or may not be helpful, or it can be with existing faculty. Um, when I applied to Texas, I I actually showed up with my sister. My sister was a medical student at the time, and she was like, "Let's just go to the school and meet some people." We literally knocked on doors. We were, which was insane, but we started knocking on doors. I met faculty, and I was just like, "Hey, I'm a pre-dent. Like, I'm really interested in coming here. Can you tell me a little bit more about what it's like to be a student here?" People love talk in education. People love educating. They would love to share their experiences with you. And for those that you reach out to that don't get back to you, that's fine. No harm, no foul. Like I think that in order to stand out from the crowd, you really want your name to become familiar. So when someone picks up the application and says, "Huh, yeah, Sherry, yeah, she emailed me. Oh my gosh, she's so excited about this school. We're going to have to bring her in for an interview." Like, it's little things like that. And so reaching out to faculty members, literally Google, find, you can see these faculty profiles, try and find someone that is at a dental school that maybe went to your undergrad. So if you were to Google, let's say, like, for UNC, like Lehigh, UNC faculty. See what comes up. Some bios might come up, maybe mine will, I don't know, where you can say, "Hey, I have a question. I'm a Lehigh grad, just like you, Dr. Lee's. Like, I just kind of want to know more about the process." I would say doing that before the application cycle is a little bit better, because some faculty, especially those on the admissions committee, they cannot correspond. Like, I remember reaching out to someone in San Antonio, and she was like, "I'm so sorry. We're in the middle of the application cycle and I'm not allowed to correspond with applicants," because it, showed favoritism. So if you can, do it before the cycle starts, and just don't be embarrassed or afraid. No email is too silly. Just reach out, and you're talking to people who are in education. So they should absolutely love having that connection with you and talking with you about it. And if you don't find that right away, keep chugging to find someone else, other faculty, or existing students that can connect you with someone else in the school.
Thank you so much, Dr. Lees, for your detailed answer. Our next question is related to one of the cases you showed, and it's asking what are the cause of crazed lines?
Okay, so let's see. I know it's, here we go.
I think it's talking about, yeah, that one with the anterior implant crown.
Yes. So crazed lines are kind of an interesting thing. The structure of enamel is super unique. So it's kind of like this keyhole structure, where you have them all interlaced with one another, and they're not enamel rods that necessarily are straight. So enamel can have all different directions, and it can also take right turns, like 90 degrees. It can go in all these different directions, and that is to slow the propagation of a crack. So if we're looking at this case here, let's look at 8 and 9, because those are kind of like the standout superstars in the smile. You can see these vertical crazed lines. That happens over time. So this patient's in his mid-50s, I believe. He has had these teeth for a while. If you're a clencher or grinder, that's going to put extra pressure on your teeth. That extra pressure will cause crazed lines. He's also a heavy coffee drinker, so his crazed lines stand out more. My husband has one vertical right down the center of his central, and we think that he's a big surfer. Well, not like, it makes it sound like he's a professional. He's not a professional surfer, but he's really big into surfing. And he has been surfing his whole life. And I asked him, like, "Did you ever get smacked in the face with a surfboard?" He's like, "Of course." I'm like, okay, that pressure from just one trauma, one blow, wasn't enough to crack the tooth in half per se, but it was enough to create this vertical crazed line that exists, but it doesn't propagate further because the actual structure of enamel is so dynamic and just has all these crazy turns that prevent the crack from going straight through like a porcelain plate would. if you smash a porcelain plate, it would be a million pieces. But the bilayer structure of teeth with dentin and then enamel layered on top, it's really all about just overall use and that pressure that that tooth feels, or it could be from a traumatic incident like a surfboard hitting you in the face. But usually those vertical craze lines are from just use over time, and clenching and grinding can accelerate that process.
I have a follow-up question. Could it be also due to like removing braces?
I would say that's a pretty. I've never seen it. I've never seen it. I'll never say never, but really the way that the braces are bonded on, they're with resin, and when it does feel pretty aggressive when they're kind of twisting the brackets off, but the way that it's twisted off feels like a lot of pressure, but it wouldn't shear enamel in that vertical sense. So I'm not saying that it's impossible, but it's pretty unlikely that braces would torque the tooth in a way that you can get that vertical crease line there.
Thank you.
It's a good thought. I like that the wheels are turning, and we're thinking about those undue pressures that teeth feel.
Thank you, Dr. Lees, for that explanation. The next question is, what is one piece of advice you would give to a future dentist that you wish someone had given you?
Oh, I could talk for days on this. Okay, one piece of advice. Okay, I'll say this. When I was in dental school, and I feel like all dental students feel this on some level, when you're in the healthcare profession, you put a lot of pressure on yourself. It's a high stakes field because you have patients that are like aware of what's going on. One of my best friends, she's a neurosurgeon, and her patients are out cold when she's working on them. So there's a lot of pressure for her in a different way. But for us, the pressure is really about taking care of these patients that have trusted us in with their teeth in our hands. And that's a lot of pressure for someone. When you're in dental school, one of the things that I had to really learn was, and this became my mantra for life really, is to get comfortable with being uncomfortable. Dental school is uncomfortable. I see it every Monday and Friday that I'm with my students. I relive it with them. It's uncomfortable. Your third year, you have just a series of firsts. First injection, first crown on an anterior tooth, first crown on a posterior tooth, first crown on a root canal treated tooth, first crown on the lower, first crown on the upper. Oh, this is my first filling. This is my first, everything. There's 32 teeth in the mouth. There's a lot of different things you can do to them. Everything feels so new. And I remember my first couple of months in dental school, I would go home and cry because the first 2 years are didactic and you're just waiting. I got to get to clinic. I got to see my patients. This is why I'm here. This is my calling. I'm here to help people. And then when you're there, you're thinking, it's almost like imposter syndrome. You're like, I can't believe that this is my first. You don't share that with the patient. You have to be on, right? You have to be confident. You have to project that confidence to make the patient feel comfortable. And so I was just uncomfortable all the time. And it was because it was my first time doing stuff that I had never done on a live patient before. And that was very stressful. And I just had so much pressure that I put on myself that I really had to get to a point where I would walk in and say, I'm planning on doing a filling today. Who knows what the dental gods will give me? And patients would come in and it would be like, oh yeah, we're going to do that filling there. Nope, this tooth broke last night. You're going to be doing that. And it was almost like I settled into this zone of like, what's the adventure today? This is going to be wild and I'm going to get through it. I just got so comfortable with being in this zone and this world of firsts and discomfort. And the sooner you get that, and the sooner you embrace that feeling of, oh my gosh, what am I doing? We're going to figure this out little by little. You will see yourself excel because the pressure's off and you're ready to just tackle whatever comes your way. I had crazy situations. Like I had a patient who we were trying to take a temporary crown off. It flew. With all the pressure, I was trying to take it off. We couldn't find it, right? We were looking everywhere. A couple of minutes into me searching on the floor, and next door I had faculty helping me. The patient goes, I think I feel something in my ear. Her temporary crown flew off and fell. She was laying in the chair and it fell in her canal, in her ear. Like, I was just like, you can't make this stuff up. You know, dentistry is wild. And there's things that you will see that you just would never have imagined. And it doesn't end when you get into dental school or graduate dental school. I mean, it just, things happen in private practice, but now it's kind of like, ooh, you know, what kind of cool situation am I going to run into? And I just have to rely on the fact that, and trust myself that I've figured it out before, I could figure it out now. So this also ties into reaching out to people that you don't know, that you're trying to make connections with because you're trying to get into dental school. That's kind of uncomfortable, right? Like sending an email that's like, hey, I'd love to meet up with you or talk with you on Zoom, or that's uncomfortable. It's just the beginning. So you might as well get used to it now. Put yourself in situations where that's where the growth happens. In that uncomfortable zone, you will see yourself grow tremendously. And you can't have that type of growth if you're always super comfortable in your safe space. It just won't happen. So that's my number one rule for anyone who's applying to dental school, in dental school, and even afterwards. You're just living in this zone of who knows what's going to happen next.
Thank you so much for your advice. It's really helpful. Another question is, what resources did you use to study for the DAT exam? Can you please give us some advice on the study habits?
Sure. So for me, it was tricky because the DAT had touched on subjects that I hadn't seen in years. So that was a little bit of a challenge. The resources now are better than when I had taken the DAT. But what I will say, the one resource that stood out was the DAT Destroyer. So for organic chemistry, I mean, you cannot get better prep than the DAT Destroyer. So I would say definitely invest in that. I took the Kaplan course and that was helpful. But I think really the DAT Destroyer is what put me on the next level. DAT Bootcamp, I've heard a lot of good things about. I didn't take that. I don't even think it was available back when I was applying, but I would check that out as well. And I also recommended this too. I don't have my phone with me, but I mentor a couple of pre-dent students on the side. And I was talking with one of them last night, and she was asking about PAT because the perceptual ability part is notorious for, if you get really good scores in that section, dental schools look pretty favorably on that. And my one recommendation to her was to download any DAT app, and in your free time, have fun with the PAT. When I got to the PAT section, I just remember feeling relief. Like I was like, oh my gosh, no hard sciences. This is a game. Try and have fun with it. You know, when you get to the angulation questions, some of them are just meant to purely throw you off and stress you out. If we're talking about an angle like this compared to an angle like this, I mean, who's really gonna know? You know, it's kind of the luck of the draw at that point. So you get to a point where you really try and figure out how you can cut out the blatantly wrong answers. When it comes to PAT, practice on your phone when you're watching a TV show, when you're in line waiting for something. Just soak up little moments here and there. You don't have to sit for 60 minutes and just stress yourself out with PAT questions, but kind of take it more as a fun approach to where it's a little bit of a brain, break. You're using a different part of your brain for that part of the exam, and have fun with it and just expose yourself to more and more questions. I've heard some people say that you can't change your PAT score drastically, and I just totally disagree. I think it's something where the more your eyes see it and the more you try and take that stress off of yourself and make it like it's a fun game, the better you'll be, the better results you'll have.
Thank you, Dr. Elise. And the next question is, what does UNC Dental School think about post-bac students, like especially for those individuals in a post-bac program using it to enhance their grades?
Yes. So I can't speak directly on UNC because I'm not on their admissions committee. When I was a dental student in San Antonio, we had groups of us that were interviewing students, and we really got a good look at the admissions process and just kind of we asked standardized interview questions, and then a couple of we were allowed to go off the page and ask our own. What I do know about post-bac programs is that as long as you're showing a commitment to the profession and a commitment to improve your grades, we just need to see that upwards trend. We need to know that you've learned something from where your grades were when maybe they weren't stellar to where they are now. And if you can show that upwards trend, that's the most critical part. I think it has less to do with what school the post-bac program is from, or what exactly what the post-bac program is centered on, and more about what courses were they, are they heavy science, and can you see that upwards trend? And I think it's also important in your essays to really point out what you've learned in the post-bac program that will make you a better student. So if it's time management, if it's coming up with certain methods to study, if it's developing your own flashcard system, like that's what we want to hear. We want to say, okay, student XYZ has really taken this post-bac program to learn about themselves and excel in every way so that they're a great dental student. We think that they're ready for dental school. So it's really more about the trend, but I think it's a great way to go and really focus on the lessons that you've learned along with that upwards trend, and just trying to get that across in your application.
Thank you, Dr. Lees, for your answer. Another question is, if you don't mind sharing, can you discuss your experiences with loans and finances?
Sure. So many things to go into. So I'll start with student loans are a necessity. I mean, I had a couple of classmates who were lucky to come from families that could really help them throughout dental school, but that is such a minority of the dental school population. Really, dental school student loans are just a fact of life. And so when you're looking at the dental schools, I'll speak in like a general term, really, the tuition rates vary greatly. So I wasn't looking at that when I was applying because I just wanted to get in. I was just so focused on how do I become a dentist, and it's a good enough career to where, okay, I can pay it off. And it is a great career, but so much is out of your control. For example, the student loans that you take on, especially like mine were federal student loans, those interest rates were set when I took them out in 2013. I had no say on what the interest rate was. So in 2013, I think my student loan rate was like 6%. And then in 2014, the federal student loan rate went down. So it was like 4.5%. That's out of your control, but that follows you for the rest of your life now, or for the eternity of the loan. What's interesting is you always have the option of consolidating your student loans after you graduate. The tricky part there, and this is what COVID really kind of highlighted, was that if your loans were federal, like mine were, when COVID hit and the government started changing rules, my loans were frozen. They're at 0% interest right now. The government said, okay, we're not going to incur that interest rate. So that saves me a lot of money because the interest rates were frozen up until September 2021. If I had consolidated, if I said, I'm going to take my student loans, go to a private company and consolidate them, then I owe that private company my new loan balance. And that loan balance might have a slightly lower interest rate, let's say my cumulative interest rate for my federal loans ended up at like 5.5%. Maybe if I consolidate them, I can get it down to 4%. So you're thinking, great, you save money over the lifetime of that loan because you've decreased your percentage. Except for my classmates who did consolidate their loans, they owed all of that money even when things were shut down. So when the government said, you don't owe us for the federal loan because we understand people are losing their jobs and not working right now, the private loan companies were not that forgiving. And you really, I mean, some of my friends had to call the company and go into forbearance or different situations. But when you take things out of federal, it really complicates things. So a lot of people have, had the discussion about like, do you consolidate? Do you not? I think you have to look at your financial situation and figure out what's best. I will say that not consolidating was super helpful. I also found out this very grim and like horrible, morbid thought but I spoke with a financial planner who said, if your loans are federal, God forbid something happens to you and you pass away, your husband is not liable for those student loans because the federal government will forgive them. If they're private and I consolidate them, then unfortunately my husband's still on the hook for that. And that was kind of like I hope I'm here for a very, very long time, but it just kind of made me think maybe that extra savings and percentage isn't critical at this point in my life. I'm just going to keep it federal. You also have the advantage when your loans are federal to look at possible options post-graduation, whether it's working at a Native American, like a health reserve. If you work in a low-income area that's remote, that the government has identified as a specific high-need area in dentistry, and you work there for a certain amount of years, I think it's 10, then your loans can be partially forgiven or fully forgiven if they stay federal. But if you consolidate, you don't have that option. So if you end up going into teaching full-time, which I'm not doing, I'm doing part-time, so I don't get this benefit. But if I taught full-time for the next 10 years, I also have that option to have loans either partially or fully forgiven if they stay federal. So I would say that the student loan amount, it's going to be there for every dental student, but how you manage it is really important. And, I was fortunate enough to talk with a financial planner who recommended, hey, your student loans are 0% right now. You can pay them and it'll just go to principal, and that way you can lower your overall amount. Interest is really the killer for student loans. And that's what I didn't understand. The downside is you don't have control over the interest of your student loans when you go into school. It's kind of the economy, but you guys are in a good spot in the next year or two. I just can't imagine interest rates being high. So you're in a fortunate situation there because when all of you get accepted and go to dental school, the interest rates will be pretty low. I'm hoping. Was that helpful?
Thank you.
Yeah.
Yeah, that was very helpful. Thank you, Dr. Lees.
Sure.
So even though it's a little bit early for us pre-dental students, could you elaborate more about like what it is like to be a dental associate and the pay that like you should expect?
Yeah. So as a dental associate, there's definite pros and cons. I think that at this point in my career, it's a perfect fit for me because I got to experience already just 2 different offices and how they operate. And I'm already pulling things, from each experience so that one day when I own my own, I really can make it exactly what I want it to be. And I think you really need to get experience from other places to understand what you like and don't like. As an associate, it varies, and it definitely depends on how competitive the area that you're in is. If it's highly competitive, then the chances of you getting paid very high just getting out of school is lower. But if you're in a more remote area or an area with high need, then it could be higher. When looking at payment, companies or practices will do it a couple of different ways. There are some practices that will say, dear Dr. So-and-so, we'd love to hire you For the first 3 months, we're going to give you a daily minimum. And that daily minimum is whatever you agree upon. I've heard it range from, $575 to $1,000. It varies. We're going to give you a daily minimum. And what you do in your day will depend, but it probably will be a little bit lighter than normal because you're starting out and you're just getting to know our patient base. After month 3, you'll collect, 30% of collections or production, depending on the practice. Collections is what the office actually gets payment-wise. Production is what you've done. So an example of that would be, if a crown, again, $1,000, we'll use that example. If I do 3 crowns in a day, that's $3,000. That's my production. But what has the office collected? Is it a PPO office? Because then it's not going to be $3,000, right? It's going to be less than that. Is it a fee-for-service office? Great. Are they collecting 100% of their fees from patients? Some offices, they have to chase patients down and they're not able to get, so really if you're looking at, I think it's like 96% or higher collections, that's great for an office. But some offices don't collect that high. And so you have to really look at that and see which practice you're applying to, whether or not your percentage is going to be based off of collections or production. And then also you will have deductions from your pay in most offices for lab fees. So if I take a case that's 20 crowns and we owe the lab, I don't know, however many dollars, then that would be deducted from my payment for that month because I was the one that did the work and incurred the lab fees. So when you're talking to the owner dentist, all of this can be figured out in your contract and you can tweak things there. 30% is pretty standard for production or collections, but 30% of what you would take home. And that's after lab fees and all that.
Thank you so much for explaining. Another question is, how do you know if a dental school has a good clinical component? Do you think UT Health St. Antonio prepared you well clinically for the real world? I know you did another year, but just if you would have not done that.
Yes. So that's a great question. I love that I've seen 3 different dental schools in my time. So San Antonio, ECU, and UNC. Each school has its own flavor. So as an applicant, again, you're just trying to get in. So it's hard to really hone in on the details, but I would absolutely talk to students and ask faculty, what are the requirements to graduate from this dental school? San Antonio more than prepared me for a life in general dentistry. It was in a massive city. San Antonio is, I think, the 7th biggest city in the country. There is a significant population there that has middle to low income, and they're in need of dental work at low cost. And so San Antonio, there was no shortage of patients. The fees for the stuff that we were doing were very reasonable. Crowns were around $300. That's incredible. And so getting patients to accept that type of treatment was easy. It really wasn't a battle because the fees were so reasonable and there were just so many patients that were there. And our clinic experience, I think, was just bar none more than prepared me. I remember in my residency program talking to some co-residents and just being surprised at how vastly different the experiences were. I also believe that whatever dental school you go to, so much of your clinic experience will be based off of you and what you make of it. If you want to sit back and relax, you can do that. If you want to soak up every minute of it, you can do that. It really, a couple of classmates and I remember just, we developed such great like relationships with our patients in dental school that they trusted us. We could talk with them about all these options and they would say, yes, let's go for it. Yes, it depends on how you communicate with your patients and how driven you are, but you can squeeze so much out of it. We had an implant selective where 8 or 10 seniors were chosen out of the class of 100 to place implants. And thankfully, I think my background in implant dentistry prior to dental school and how I did in dental school helped me get chosen for the selective. But to be a 4th-year dental student placing dental implants on patients was like beyond. I didn't even know that happened. And so some dental schools don't have that program, but when you're talking to these people that you will now be reaching out to at dental schools to make these connections, ask them, what type of selective programs do students have an option to partake in? Do they have an implant selective? Do they have an Invisalign selective? What alternative things can you add to your schedule? And really, what are the minimums that students are graduating with? What's an average senior doing as far as crowns go? I think that those are really important questions that you need to get down to the nitty-gritty, because it varies wildly depending on what school you go to and how driven you are within that school.
A follow-up question, do the dental schools provide their patients, or do you have to find your own?
Great question. So it is a mix. At UNC, ECU, and San Antonio, the school has a pool of patients that are kind of like sifted through, and they kind of figure out which department they belong in. And when you're in clinic, you are given a certain amount of patients. But the tricky part about that is that some patients will be great and some will never pick up the phone. So it's really tricky to rely just on that. What we ended up doing in San Antonio, my classmates and I, is we would, at every chance we got, talk to, if we had great patients, where's your husband? Oh, your sister needs some work done? Tell her, here's my card, text me. It was all about how do you use the patient's population that you have and branch out so that you get more experience and more clinic time. And really, I remember having some patient cancellations, and we would run to like the medical building next door and go into waiting rooms and ask people like, oh, would you like to be screened? We're at the dental school right next door, and we can get a panel for you. Like, we were just so proactive. And I would let anybody know I was a dentist. I posted on Nextdoor in my neighborhood, saying, I'm a dental student, and it's $40 to be screened. I would love to come see you. It was just, I couldn't find enough time to find my own patients. And so if I had patients that I wanted to bring in, then I could do that. And at UNC, ECU, and San Antonio, if you have family or friends or patients that you know of that you want to bring in, you can bring them in. They just go through slightly different processes at each school to onboard them.
Thank you, Dr. Lee. And the next question is, do you have any advice on how you studied during dental school and manage your time?
Yes. So dental school for me, it's interesting because there's different phases of dental school that you experience. So for me, first year and second year first year was all textbooks all the time, right? Like, you're just trying to get through histology and anatomy, and like you're just getting the information thrown at you. And it was very heavy on the didactics. So for me, I had, I'm going to see if I can pull it up. I still have so many of my dental school books, but I would do these crazy study sheets that I still have. Yeah. Okay. Sorry. So I had these crazy study sheets that I still have, where for me, like, I needed to write stuff out. I needed it to be pretty. I needed things to be color coded. I needed to have things very organized. And if I was taking the test, like I would see these notes and be like, oh yeah, like I could remember what I had written out. Sometimes I needed to write things out 10 times before I got it. I did lots of acronyms. I had all these crazy sayings. And yeah, I would draw little pictures like, here, this is something about, yeah. So squamous cell carcinoma, right? Where is it found? So 2/3 of squamous cell carcinomas on the posterior lateral border of the tongue. So I would literally draw a little tongue and just, I needed these visuals to keep myself going. So for didactics, I was very heavy into, I have so many of these study sheets. It's scary. I just can't give them up because I put so much work into them. So that's one thing. And then another thing that I would do is I would take information and put it into the form of a test question. And I would fold my sheet in half. I wish I had an example of this. I had a whole notebook of this, but I would basically do something like this. So I would write the question on one side and then I'd have the answer on the other, and I would just flip through it all the time. So I would quiz myself and ask myself questions based off of the material. So I would reformat the material so that I could do it in like a question and answer type thing. And that really helps with a lot of the nitty gritty details that you get in like microbiology and oral pathology. There's just stuff that they give you where it's just rote memorization, and that was what helped. And repetition. Like I had to read those, I don't even know how many times before it actually stuck. But for me, the way I learned was like physically writing stuff, making it pretty and visual, and then repetition with just questions all the time. Second year, you get into lab, right? And that's like, and first year at some schools, you do that as well. And lab was more hands-on. So I was lucky to find out that I didn't need to spend a lot of time in lab, and I still needed to work heavy on didactics because that was my more challenging side. And so every student's different. When for the students that were super strong in didactic, they would have a hard time in lab sometimes, you know, and they would have to spend extra time in lab to really make up for it. And that's just practice, you know. But third and fourth year, it was just at that point, again, being comfortable with being uncomfortable. And for the boards exam, all of the both first and second boards, part 1 and 2, I went back to all of these sheets because this is all information that ended up on them. And I just kind of had to see things a million times for it to stick, but eventually it does.
All right, and one last question is, what other questions do you recommend asking dental schools to see? What other activities you can do during dental schools?
Okay, so that's a great question. I would ask about what type of free clinics they host. So lots of schools will have clinics that are student run, and it just gives students an extra time to volunteer and work at these clinics. I know UNC has a couple, San Antonio had a couple. Really find out what type of extracurricular opportunities you would have through these volunteer clinics. In these volunteer clinics, you'll see patients who have a dire need for dental work. And so those are really some of the best places to get experience. So I would ask about free dental clinics and what type of volunteer clinics they have. I would ask about what averages are students graduating with. It might be worth even asking, you know, what's their board, like the licensing exam, what's their pass rate? It should be pretty high. It really should be pretty high, but that'd be interesting to know, just like how many of your seniors are passing their licensing exams on the first try. I would probably ask if it would be great to know if the dental school had any funding available for patients to get additional care if they can't afford it themselves. So lots of schools will have money set aside for cases that you could potentially apply on behalf of the patient for certain treatments. So, for example, patient's a perfect candidate for implants, but she is a single mom and her son is 2 years old, and she has a dog that, has medical need, and I don't know, like there's so many things that patients have in real life that when you hear their stories, you're just like, oh my gosh, there's got to be a way to help you. And some schools do have some funding set aside for that, so I would ask about that as well.
Thank you, Dr. Lees. Unfortunately, that is all the time we have for questions today. I just wanted to say thank you so much for taking the time to answer all of our questions and for all of your advice. To everyone who joined our session today, the post quiz will be posted in our group meet. And yeah, I just wanted to say thank you again, Dr. Lees, for being here with us.
Well, thank you for having me. I hope that I answered questions and really inspired someone out there to continue on their journey. Please reach out to me. You know how to get access to me, and please stay in touch. I wish you all the best of luck. And thank you. Thanks for tuning in on a Friday night. Go all of you guys. Yes, that is determination.
Thank you so much, Dr. Lees, once again. It was very informative, and we